Now, this talk is going to cover the basic principles of pre-hospital mechanical ventilation. Now, the main references I used, first off, was the Ventilator Management book by FlightBridge ED. This is a fantastic book for anyone who has interest in this topic. I really recommend it for any level of provider. Also, Rebel EM blog has a great series on mechanical ventilation, and JaxEMS in 2015 put out an overview article. So I'll admit, I don't know much about transport ventilators. We're going to cover the LTV 1150 for this talk, but I've never used this ventilator before in my practice. I have ventilators in my hospital that have a lot more bells and whistles, have nice fancy screens and graphics that make me feel good. But again, the basic principles are the same no matter what ventilator you're talking about. Most importantly, we need to understand that we're just going to scratch the surface of this topic. You can talk for hours and days and have entire conferences on this, but we're just going to talk about the very basic principles that the basic provider and even the advanced provider can use to put together the right ventilation strategy. All right, so you've intubated the patient. It was a tough intubation, but you got the tube in. Now it's time to celebrate. You go be you. You do your little dance in your truck. But we need to understand that we can't just stop there. It doesn't just stop at the intubation phase. We need to think about the mechanical ventilation phase if we're a transport or critical care unit. So someone's going to ask you, what would you like for your settings? And first off, we can't just look at them back with a scared face, and we also can't just say, oh, let's do the cookie cutter. Let's do what everyone else does for every other patient, because not all patients are the same, and not all physiology and disease states are the same. So we need to have a more organized and structured approach to this. Now, to make it a little more fun, we're going to think about it from a music producer standpoint. So putting a song together, producing the music, all different components that have to come together for that. It's a very complex system and complex process, and it's kind of similar to mechanical ventilation. Just for fun, we'll have a music producer theme for this. So first off, we'll talk about breath types. Now, the three main breath types, there's control, assist, and spontaneous. For control breaths, the machine does everything. The machine triggers it, the machine says how long it's going to happen, how much volume is going to go in, and it does everything itself. In the assist type of breath, the machine helps the person. So the patient actually triggers the breath, but the machine gives the set amount of volume or pressure that's been indicated by the provider. In the spontaneous breath, all the work is done by the patient. Patient triggers, the patient says how long it's going to happen. It's essentially just a natural breath. Now you can add some support with pressure, but basically it comes down to the patient's. Now, to put this in the music perspective, for the control breath, that's kind of like a beat generator or a drum machine. You set the rhythm you want, you set the tempo and all the different components, you press play, and the machine just goes. All right? So just like a ventilator, it just goes and gives the breaths that you set, and that's what it does. When we talk about assist breaths, it's kind of like picking up the instrument, picking up a guitar, and then having a pedal or an effects board with you. So again, you're initiating the action, initiating the music, but you have some other components and fancy machines that are going to actually help you and assist you with that action. And the spontaneous breaths are like the vocals, the singing. The patient or the singer is initiating that action and doing pretty much all the work. Now you can get some support through a microphone amplifier, but for the most part, the patient or the singer is doing the work. Now there's some different targets we can have when it comes to mechanical ventilation. The two main ones are volume target and pressure target. So these two balloons were filled up with these different targets in mind. But you can see the end result is pretty much the same, but how they get there is a little bit different. So we look at the volume targeted on the left side. So you set a volume into the vent and say, that's the volume that I want. If you look at the flow curve on the bottom, on the left side, it's going to give a constant flow until we reach that volume. For that reason, the pressure readout is going to gradually increase until it reaches that volume and it's going to drop off. The pressure targeted roll, what that's going to do is you're going to enter a pressure, a set pressure. And you can see by that pressure wave on the top right, it quickly ramps up to that pressure and constantly gives that pressure until the desired effect is achieved. Now, for any Bruce Springsteen fans out there, you can kind of equate this to different styles of his songs. So on the left, for volume targeted, we have Thunder Road, a fantastic song. Essentially, the way Thunder Road is structured, it's a constant stream of words, a constant stream of message that just keep flowing without obvious structure. There's no chorus, there's no verse. The words just stream until the final goal of the song is reached, the final volume is reached. Now, if you think about Born in the USA, it's a very structured approach. It's a chorus, verse song that flips chorus, verse, chorus, verse as a pattern. So that can be thought as your pressure. So you set the pressure to that chorus and verse structure, and you repeat that over and over and over and over again until your goal is reached. So you can see kind of the different structures in the song. Now we're going to talk about modes, the different modes of mechanical ventilation. So if we go back to the LTV 1150 ventilator, and we zoom in on the bottom here, we can see these buttons help us select the mode. So on the left, we have the volume and pressure button, so the targets we just talked about. And on the right, we have different modes that we can select. So the first one to discuss is control. So there's not actually a control button on the LTV, but if you set it to AC and then bring your sensitivity to 0 or to double dashes, that makes it control mode. And what control does, like I said before, the machine does all the work. So the machine initiates the breath, it determines how long the breath is going to happen, and it dials into the volume or the pressure that you set. So in my opinion, control breaths are kind of like EDM. They essentially have no role in this world. So we won't get started on why EDM has no role in this world, but control breaths are really only used in the OR setting. It's when someone is under general anesthesia and you need that machine to do all the work for you. So in the pre-hospital phase, really not going to be using that too much. Now the assist control mode, it uses the control components, but also adds an assistant to it. So that very first breath you see on the pressure wave, that's a control breath. The machine is giving the exact breath that you told it to. Now, those next two breaths that have that little purple circle, what those are, that's the patient initiating the breath. So the nice thing about this mode is, on top of the control modes, if the patient wants to take a breath themselves, they can. And the machine will give them the volume or the pressure that you specified every time they take a breath. Now this is kind of like bluegrass or rock. So you have an underlying bass line, an underlying band that's keeping the rhythm, keeping the song going. But if the banjo player feels like stepping up and taking a break and throwing out some licks, then he can. And he can kind of go do his own thing, all the while the band and the bass line is running behind him and supporting him. This is going to be your most common mode that you see in the hospital setting. And most pre-hospital and transport units as well, probably. It's a nice mode because, again, it kind of meets the minute ventilation requirements of the patient. It keeps the patient a little more comfortable because anytime they trigger the vent, they're able to take a breath, as opposed to the control, where if the patient tries to trigger a breath and the machine isn't ready to give one, they're not going to be able to trigger a breath. Now, there's ups and downs to every mode. With assist control in general, you know what you're getting. So you dial in the components, the parameters that you want. That's what the machine's going to get. And the patient is allowed to initiate their own breaths. Now, some of the downsides that every breath gets a full tidal volume. So if for some reason your patient is in pain or obviously experiencing discomfort from being intubated, then every time they breathe, if they're breathing 30, 40 times a minute, they're going to get a full volume of breath. And that can be pretty uncomfortable for a patient. It can also maybe throw off your arterial gases a bit. So, and also there's vibration interference. And this is what's going to be the issue with transport units, and just something to be aware of based on the machinery and the system that you have. In this video here, specific to the LTV 1150, we can see that as he turns the sensitivity knob down to 1 and shakes the machine, essentially to simulate being on a helicopter or ambulance, the machine itself is sensing those as patient breath and are actually giving more breaths because of it. So it's sensing that as the patient trying to take a breath. And because of that, even though the rate is dialed into 18, the machine is now giving up to 30 breaths a minute. So this can be an issue. If you've dialed in 18 for your patient, and now just based on the helicopter or ambulance vibrations, your patient's getting 30 breaths a minute, this can really throw off the physiology. So something you just have to be aware of. For this reason, SIMV has been a popular mode within the pre-hospital phase. It's pretty popular in hospitals, but kind of has lost some favor. So the way SIMV works is that you have a set number of breaths that you want to give, and the machine gives those breaths. But it also synchronizes them with the patient's effort. So if the patient wants to take breaths, it allows that. It doesn't give the full tidal volume breaths, but it allows the patient to have some breath effort. And you can add in some pressure support to help those as well. So I kind of see this as jazz. So your underlying breath rate that you put in the machine, that's going to be your bass rhythm. That's going to be what's going to be continuing to go in the background nonstop throughout the song. But then the trumpet player is going to step up and do his own thing. And if he wants to do his own thing and have fun, then he can. But all the while, that bass line is going to be synchronized with him behind. Now, the positives of this is the patient's allowed to initiate their own breaths. It can be a more comfortable setting. You also get guaranteed minute ventilation. So minute ventilation is going to be our respiratory rate multiplied by our tidal volume. So you're able to dial that in into SIMV. And if they're taking 40 breaths a minute, they're not going to be getting a full tidal volume every time. So they're not going to be throwing off their minute ventilation. Now, like I said, not all breaths get a full tidal volume, and you have decreased vibration interference. So one issue is that this may actually lead to patient fatigue, because again, it's allowing the patient to breathe as much as they want. And so if they're breathing 40 times a minute, they may tire out. And there's actually no proven benefit. So at first, it's very exciting to get this mode in the hospital, especially because people thought maybe it could be a good mode for weaning people off the vent. But to this day, there's really hasn't been much proven benefit. So people have kind of fallen back to using assist control. And then finally, pressure support. So pressure support is just what it sounds like. It gives a little bit of support through pressure. On the LTV vent, the way you get this is putting it in SIMV mode and putting the breath rate to double dashes. So think of pressure support as a very thick milkshake with a straw. Now, it's very hard to get that milkshake through the straw, but the pressure support is adding water or some other agent to thin out the milkshake and make it easier to drink. That's pressure support. So think of freestyle rap battles. Again, the patient's doing everything themselves. The singer's doing everything himself. We might have a little support from a microphone and an amplifier, but otherwise he's doing all the work himself. The pressure support just eases that work a little bit. The positives of this is the patient's allowed to initiate the breaths and allows for more natural breathing. So this may be a mode that we use in the hospital, especially when weaning someone. If maybe we just had to do a procedure, a GI procedure, and scope the stomach or something, and now we want the patient to actually come off the vent, we might use pressure support. But the question in the field is, does the patient really need to be intubated if they're just on pressure support? And that's something for you to decide. So we've talked about the types of breath, we've talked about the targets, we've talked about the mode, and that brings together our ventilator strategy. Very similar to song structure. We talk about the overall structure of the song, different components we want, and also the styling of the song. That brings together your song blueprint. Well, once you have that, you need to start fine-tuning to make the final product. So this is where we'll talk about the parameters of our mechanical ventilation. Now, those parameters can be found in this area of the LTV machine. The ones we're mainly going to talk about can be breath rate, tidal volume. We'll also talk about FiO2 and PEEP. So your breath rate is your tempo. It's your song tempo. So we can have a whole spectrum of tempo. We can start off with Kenny G, nice and slow if you want to go to sleep. And on the other end, we can talk about Angus Young, very fast and loud. So with most mechanical ventilation, if you're lost and not really sure what to do, just think about what most humans do for homeostasis. We're usually going to be somewhere in the middle of those extremes. There will be reasons to go out to the extremes, which we'll talk about, but in general, we'll be somewhere in the middle. In tidal volume, same as before, we can have very soft Kenny G, and on the other end of the spectrum, we can have Angus Young blasting out your ears. And somewhere in the middle is homeostasis. And tidal volume is going to be a very important component that's often overlooked, and we'll talk about why that is in a second. But most importantly, with tidal volume, we need to talk about stressing the alveoli. So the alveoli are obviously very important for gas exchange, and when we add too much volume to them, we actually cause damage. We can cause damage to surfactant. We can wash out many gases that cause them to collapse too much. We can stress the alveoli, and the end result can be long-term damage to the alveoli, leading to things like ARDS. And so we really have to be cognizant about what volume we're putting in. These days, based on recent research, we're finding we need to put a lot less volume than we once thought we did. And the most important thing to hammer home and understand this is most of our lungs are the same. For adults, they're the same size. Just because there's a 100 kilo person and a 300 kilo person doesn't mean their lungs are different sizes. It actually comes down to the height of the patient. So again, it's not just the weight of the patient, it's the height of the patient. So that's when you need to start talking about ideal body weight. Now there's equations for this based on whether you're a male or a female, but you can see it's based on the patient's height. And this is very important to understand. I like to use an app called MD Calc, and it's just a nice free way. It has multiple different calculation scores in there, but it has ideal body weight calculator. I can just put the patient's height in, and it gives me their ideal body weight. So as opposed to actual body weight, I'm using their ideal body weight when it comes to mechanical ventilation. Another nice thing to have on the rig or on the helicopter or in the recess bay is a tape measure. So you're not just guessing the patient's height, you can actually get an accurate height. PEEP, where most of us are familiar with, positive and expiratory pressure. It's kind of like the running bass line of the song, kind of holds the song together and makes things flow well. So this balloon right here, if you were to start with that flat balloon on the left and then blow it up, you know that those first couple breaths are the hardest to initiate because that balloon is completely flat. As you blow up the balloon more, it becomes easier and easier to blow it up. And then you exhale and the balloon collapses down again. You can view this balloon as our alveoli. If you look at this experiment here on the left, the red balloon that has no PEEP added. The right balloon has PEEP added. So what you can see is that the PEEP is doing is actually keeping that balloon slightly inflated. For this reason, it's easier to inflate that balloon. It's like I said before, you're skipping those first initial breaths, and now the balloon is slightly inflated and it makes it easier to inflate. Also, unlike the red balloon, the yellow balloon is not collapsing down. So alveoli that pop open and collapse down over and over again while under mechanical ventilation, this can lead to long-term damage and troubles with oxygenation and fluid buildup. So this is where PEEP helps. One, it helps the alveoli stay open and therefore opening more easy, and also keeps the alveoli from completely collapsing down. We look at a more real-life example of this. Right here, they're doing a bag valve mass ventilations. You can see his lungs are collapsing completely down. Now he adds a PEEP valve, and within a few breaths, you can see his lungs are completely inflated and staying fairly inflated. They're not collapsing all the way down. So you can see how you're going to ventilate that patient much easier when you have that PEEP valve on. And now when he removes the PEEP valve, you'll see the lungs go back down. So the good things about PEEP, it again helps alveolar recruitment, it eases alveolar opening and decreases alveolar collapse. There are some downsides. It may decrease venous return, and excessive PEEP can be harmful, but if we use it correctly, it can really help your ventilation. Then FiO2. FiO2, so inspired oxygen. Oxygen is one of the main reasons we ventilate someone. We really want to augment their oxygenation. So this is the lyrics of the song. This is really the meat and potatoes of why you write a song. And so it makes sense that oxygen is important and we want to include it. But remember that oxygen is also toxic. So at prolonged levels and high levels, oxygen can be toxic. At very high levels and high pressures, it can cause seizures and other issues systemically. But in the lungs, long exposure to increased oxygen level can cause tissue damage and long-term morbidity as well. This is primarily based on the ARDSNet research. And a couple trials that they found that the people who are on higher levels of oxygen for a longer time had longer stays in the vent and actually died more as well and went on to develop more long-term morbidity. So bringing this all together, we'll talk about how to approach this patient. So you come and look at the vent, it can be very confusing. There's lots of buttons, there's lots of numbers, there's lots of things to think about, disease states and different physiologic states, but we're going to try to simplify this down just a little bit. So you've got your patient intubated in front of you. Now the next step, I think, is to try to simplify the categorization. Yes, there's lots of different diseases that can make you intubate someone and put them on a vent, but if you can at least get it down to two major categories: the injury category and the obstructive category. For injury, this can include severe metabolic acidosis, also refractory hypoxemia. And if you look at all the reasons for that, ARDS, sepsis, DKA, and other. So for the most part, if you look at the obstructive category, it's asthma and COPD. For any other reason that you are intubating someone, you're pretty much going to put them under the injury category. And the reason it's called injury is that we're going to have a lung protective strategy and try to avoid injuring the lungs through mechanical ventilation. Now for both these broad categories, Old Faithful essentially is assist control with volume target. That's what we're going to use in a lot of our patients that come in the emergency department. And it's a good first step in the field as well. Now you do have to think about if your mechanical ventilation machine has issues with interference from vibrations from your rig. If that's the case, you may consider something like SIMV, or use the sensitivity button on your machine to make sure you avoid that. If we go down the injury pathway, our goal is to match the minute ventilation. So the person's breathing 30 times a minute before and they're acidotic. That's the reason they're breathing that fast. They're trying to blow off some acid. So you want to try to match that. If you go and intubate that person and then ventilate them at 12 breaths a minute, you can cause some damage because now they're not able to offload, and now you're the one in charge of their ventilation, especially if you used a long-lasting paralytic. So again, your minute ventilation is going to be your total volume times your respiratory rate. Tidal volume goal is about 6 mLs per kg. I think that's just a good number to memorize. There's lots of different ranges, but again, going back to those ARDSNet trials, we originally were doing 10, 12 mLs per kg, but with those trials, we found really a lower volume strategy, around 6 mLs per kg was the best way to go. Your respiratory rate is going to be a broad range. Again, you're essentially matching your pre-intubation minute ventilation. And then your initial PEEP and FiO2 can be set at 5 and 100%. We'll talk about how we change those afterwards. For your obstructive group, you want to facilitate exhalation. We'll talk about why that's important. your tidal volume range, you can go up to 8 mLs per kg, because you actually may have, because we'll see how PEEP is really the way we want to go with this. But you may have to use a higher volume just to offload some CO2. Your respiratory rate is going to be pretty low. So before, we're kind of putting it wherever we need it to match minute ventilation. But for this group, you really need to aim for low respiratory rate, usually starting around 8 and going to a max of 12. And we'll talk about why that's important. And the PEEP and FiO2, again, initial 5 and 100%. So this isn't the Ronco roaster. We can't just set it and forget it. We have to stand by that machine and start adjusting dials and adjusting different settings to make sure we have the right pathway. Now, initially said set the FiO2 at 100%. Now, we can't leave patients on that. Again, that's where you get long-term lung damage. So after about 5 minutes, it's best to go ahead and decrease this down to 30 or 40%. Don't just slowly titrate it down. Go ahead and decrease it pretty rapidly and then see what the patient is doing. For your injury grouping, again, we're going to match our minute ventilation. We're going to use end-tidal CO2 or ABG. So if before you intubated them, especially if they're in severe acidosis and their end-tidal CO2 is 15 or 20, try to match that after you intubate them. Don't let that start creeping up. And then avoid hyperoxia. And the goal O2 sat is 90 to 94%. Now, it's maybe lower than you used to, but it's okay to have patients this low. We don't want them at 98, 99, 100% for long term. So really 90 to 94%. And the way we're going to achieve that is not dialing up that FiO2. So we're going to dial it down to 30 or 40%, and then we're going to use the PEEP along with FiO2 to try to bring up that O2 sat, or the arterial oxygenation if you're using an ABG. But you can see these charts here. We're actually going to start going with PEEP. So we're going to go to PEEP of 10, PEEP of 12, and then slowly bring our FiO2 up along with it, because we're using PEEP to recruit those alveoli and stent open alveoli and allow for better oxygenation. So we're trying to avoid that high FiO2 for long periods. For our obstructive grouping, we need to monitor for air trapping. So what air trapping means is someone with an obstructive disease like asthma, every time they take a breath in, air gets trapped in the alveoli. It's not a major issue except for if they keep breathing, keep trapping more, now they're overinflating their lungs. This can cause some bad physiology, especially decreased venous return. They're no longer able to take deep breaths. They're not able to offload their CO2. So this can be a pretty big problem. So in this strategy, we're going to try to avoid that. And the way we do it, like I'm going to talk about in a second, is mainly decreasing the respiratory rate. Because of that, we have to allow for mild to moderate hypercapnia. It's okay to have these people their CO2 creep up a bit, because again, we're mainly trying to avoid the air trapping. Our goal I to E is 1 to 3 to 1.5. So what is I to E? Well, I to E ratio is the ratio of inspiratory to expiratory volume. If you look at this chart right here in the green graph in the middle, we can see that if we measure the inspiratory time and the expiratory time, it's about 1 to 2. All right, so that's normal. Most of us walk around with a 1 to 2 ratio of inspiratory to expiratory time. We spend more time expiring than we do inhaling. Now, if you bring this graph out and look at the next breath, this IDE is about 1 to 6. The big differences in those graphs is that very first one, that green line doesn't come back to baseline. It doesn't come back to that horizontal black line, and that's a marker of air trapping. So you can see in this patient, by allowing a longer expiratory time, so decreasing our IDE ratio to 1 to 6, we've allowed that exhalation to fully go to baseline. We've allowed all the air to come out, and so we're no longer air trapping. So how do we do this? We can't just yell at our patient and make them do it. So we have to have a couple different maneuvers. Now, there's some advanced maneuvers you can do on the ventilator to change inspiratory time and fancy stuff, but I think that's beyond the scope of this. The main things we need to focus on are decreasing our respiratory rate and thinking about sedation and paralysis. So we started at 8 to 12 respiratory rate, and what that does is allows time for expiration before the next breath is initiated. And sometimes you have to actually even go lower than that, but also allowing for making sure that your patients are properly sedated, and sometimes even paralyzing them. If you have a bad asthmatic who's breathing 20 to 26 times on the vent and air trapping, you're probably going to have to paralyze them and sedate them so that you can now take over and breathe them around 8 to 10 breaths a minute. So that kind of wraps everything up. Songwriting, music production, very stressful, complex system just to get one song down. But if you come at it with a structured approach and you try to simplify things down and have a baseline approach to how you deal with these patients, you'll be successful. You'll be like Freddie Mercury on the left and be singing "We Are the Champions," and not like the one on the right singing "Another One Bites the Dust." So again, just simplify it down. This is a very complex topic, but practice it, run through it in your head so that you're not trying to reinvent the wheel every time you see the next patient.